So we are starting with the basic of thyroid, thyroid hormones. So let's see the structure of thyroid. See, the thyroid has thyroid follicles. This is a follicle, this is a follicle. Inside it, they have the follicular cells, and in between the follicles, we have parafollicular cells. So this T3 and T4 is made by follicular cells of thyroid, while these parafollicular cells are making calcitonin. Now the main hormone is T3 and T4. Calcitonin is just for calcium regulation. The main hormones of thyroid as such are T3 and T4, and these hormones will be stored in this space, the colloid. In between all these follicular cells, we have a storage area called colloid. So they will be stored here. So let's see how these thyroid hormones are made. Let's say this is a follicular cell, and in between we have colloid. This over here is sodium iodine symporter. So it will bring sodium and outside iodine from outside to these follicular cells. This iodine comes in the colloid. Now this iodine makes T3 and T4 hormones with the help of tyrosine from over here. We'll study more about it, but once the T3 and T4 are formed from this iodine, they are released in circulation when there is TSH stimulation. So the TSH stimulate this and these are released. Now, catch point here is that these T3 and T4 can be stored in this colloid for about 3 to 4 weeks before released. So this is a storage area for T3 T4 where they can be stored for how long? T3 for 3 to 4 weeks. Done. So now, how are these made? So let's say we have I negative. So the I negative came inside the colloidal. Now we have to make it a free radical. We have to oxidize this so that this one becomes reactive and it reacts with or combines with other substances to make T3 and T4. So the step one is oxidation where the free radical is formed. Now this free radical combines with tyrosine. Tyrosine is an organic molecule. So this process is called organification with tyrosine. Now how exactly this happens? Let's see here. See, whenever two iodine molecules combine with one tyrosine, we get DIT, and single iodine, single tyrosine, we get MIT. That stands for diiodothyronine and monoiodothyronine. So MIT and DIT are formed. So let's see here. First iodine we converted into free radical. This is oxidation. Combines with organic molecule tyrosine organification. We get MIT and DIT. Now this MIT and DIT will be coupled together. If two DIT combines together, we get a T4. And if DIT and MIT, so two from here, one from here, we get a T3. So T3 and T4 are formed in coupling reaction. So first was oxidation, then organification, and third is coupling. All these three reactions are catalyzed by thyroid peroxidase enzyme. Which enzyme? Thyroid peroxidase enzyme. Now see which will be the most abundant, T3 or T4. As our body has abundant iodine, so more DIT will be formed because it has two iodine molecules, right? So more DIT will make more T4. So T4 is more abundant than T3. Done. This we already studied earlier. Okay, so now let's see how this T3 and T4 look. T3 is 3,5,3 prime triiodothyronine and T4 is 3,5,3 prime 5 prime tetraiodothyronine, which is also called thyroxine. T4 is thyroxine. Now these are the locations where iodine is there. So T4 has 4 iodines, T3 has 3 iodines. Now whenever the iodine is at prime position, it makes it inactive. So T3 has 1 iodine at prime position and 2 iodine without prime position. So 2 are active, 1 is inactive. So T3 is more active while T4 has equal amount of active and inactive iodines. So T4 is inactive, T3 is active, means T3 is kind of more active than T4. So we first studied that T4 and T3. More abundant is T4 while the active one is T3, right? So what we need to do is we have this one as more active one, but it is made less in quantity. So we need to make T3 from T4. We need peripheral conversion. So that will be done. And to make T3 from T4, we need to remove this 5' iodine, right? So the enzyme is 5' deiodinase. Okay. So let's see what now the difference between T3 and T4. T3 has 3 iodine, T4 4 iodine. We know more active one is T3. Why? Because we have two active site and one inactive, two active site and one inactive site. So this one is more active and it's secreted less. Why it is secreted less? Again I'm saying that T4 has 4 iodines and body has abundant iodines, so body is more comfortable in making T4 rather than T3, right? So it is less secreted. And only drawback here is this is short acting while this one is long acting. The only good thing in T4 is it is long acting, otherwise it is less active, secreted more, but it's less active, right? The only good thing here is it is long acting. Done. So we studied till here that these T3 and T4 were released in the in the systemic circulation. Now they will be converted. Now we are converting T4 to T3 in the peripheral organs because T3 is more active, right? Like liver or any organs. Why are we converting? Because T4 is less active, T3 is more active, but and T4 is produced in more quantity. So we need obviously the active one which is in less quantity. Done? Okay. So now we are studying about hypothyroidism and hyperthyroidism. See, T3, T4, whenever they are less, it's hypo. Whenever they are more, is hyper. Because of the negative feedback, TSH will be less here and TSH will be more here. Now, the function of T3 and T4 is catabolism. And via catabolism, there is heat production. So, let's say heat is more produced in hyperthyroidism, so our body in hyperthyroidism is producing more heat. So we actually don't want more heat from environment, right? Because our body itself is making more heat, so we are heat intolerant. We can't stay in an environment which has more heat because inside or our body temperature is actually very high. And metabolism and sorry catabolism causes weight loss obviously. So hyperthyroidism we have heat intolerance and weight loss, and the sympathetic symptoms like heart rate, bpn will be raised. Now here in hypothyroidism there is less T3 and T4, so body is not making much heat, so we won't be able to sustain in a cold environment because our body is not able to produce that in enough amount of heat. So we have cold intolerance plus less catabolism, so weight gain and sympathetic symptoms will be heart rate and bp will be decreased, which is exactly opposite of here. So you can go through this slide. So now what is the treatment of hyperthyroidism? It's simple. Less T3 and T4, you just give them T3 and T4 drugs. Simple. Your patient is going to be treated. So treatment is T3 leothyronine and T4 L-thyroxine. T4 is L-thyroxine and T3 is leothyronine. So now which will be the drug of choice? Let's see. See, T4 is long acting and we know T4 is less active while T3 was more active, but T4 is long acting and this is short acting. So rather than being more active, we want a drug which can, you know, control the symptoms entire day. So long acting one becomes the drug of choice for hypothyroidism and mixed edema coma. But where this drug will be used, see, it is more active, so we can use this in emergency situation, which is mixed edema coma, which is emergency. In the emergency situation we are using T3 while T4 is usually used in all hypothyroidisms. Done. So now we are studying hyperthyroidism. In the hyperthyroidism state, T3 and T4 are more, so we'll be giving drugs that will inhibit the formation of T3 and T4. So right, so let's see what those drugs are. So this is a follicular cell. As we know, this is sodium iodine symporter. The iodine comes in the colloid and from iodine we get T3 and T4. So we can give drugs that inhibit this sodium iodine symporter. So those are sodium iodine symporter inhibitors. So if iodine doesn't come here, then obviously these hormones are not made and we don't want these hormones because it is hyperthyroidism. We need to decrease this. Now we can prevent this conversion iodine to T3 T4. We know the enzyme thyroid peroxidase was catalyzing all three reactions, which was organification, coupling and oxidation. So thyroid peroxidase inhibitors are carbimazole, methimazole, and propyl thiouracil (PTU). So three drugs as of now: carbimazole, methimazole, and propyl thiouracil. So now this T3 and T4 will be released in the circulation. We can stop the pathway over here also, right? So the drugs are sodium iodide, potassium iodide, and lugol's iodine. So these are secretion inhibitors. So now I told you that these T3 and T4 will be stored in this follicle for how many time? 3 to 4 weeks. Okay, we'll use this data in the next slide. Now in the liver we have peripheral conversion of T4 to T3. Why? Because T4 is less active and T3 is more active, so we are converting T3. We can stop this peripheral conversion by propranolol, propyl thiouracil, or prednisolone. So PTU was here and here also. So now you just need to remember four drugs: the peripheral conversion inhibitors, peripheral PSA, propranolol, and prednisolone done. And over here you have to remember carbimazole and methimazole, and both the place put PTU. Now the one stopping the secretion of thyroids into the blood vessels are sodium iodide, potassium iodide, and Lugol's iodine. All the iodines are stopping the secretions. Done. And NIS inhibitors drugs are not really important. You don't need to learn them. Although we'll study 1 2 in the slide. So let's start. Iodine is converted into T3 and T4. The enzyme is thyroxide peroxidase. We are inhibiting thyroid peroxidase enzymes by carbimazole, methimazole, and PTU. This is converted into these are secreted outside from the thyroid follicle. So the secretion inhibitors are sodium iodide, potassium iodide, and Lugol's iodine. Now this is peripherally converted into T3. We have peripheral conversion inhibitors which are P, propranolol, prednisolone, and PTU. PTU here, here. Thus the two different drugs are carbimazole, methimazole, propranolol, and prednisolone. Are we done? Yes. So first are sodium iodine synthetase inhibitors, NIS inhibitors. The drug is thiocyanate. This is naturally found in the cabbage, which is a rich source of this drug. If you eat more of the cabbage, you'll get goiter. And these drugs are not used clinically because they are toxic. One example is thiocyanate. Okay. So now moving on to the important ones, which are thyroid peroxidase inhibitors. We call them thioamides. Done. So we have carbimazole as a product and it will be converted to its active form, which is methimazole. Carbimazole is a product, methimazole is the active form. And another drug we have propyl thiouracil. So now this is the main hero over here. It is more potent and has better plasma T-half. So this is the best drug we have. This is less potent and less plasma half-life, but this drug is not crossing the placenta. So this is important during pregnancy. So the drug of choice in first trimester of pregnancy is this drug. If the mother has hyperthyroidism in pregnancy, we give propyl thiouracil. Otherwise, in all cases, we routinely prefer what? Carbimazole or methimazole. Plus, this PTU has one more action, which is it decreases the peripheral conversion of T4 to T3. The enzyme is 5-iodinase which it is inhibiting. So there was extra information. Okay. Now, so drug of choice in first trimester is PTU obviously. Second or third is carbimazole or methimazole. Okay. Third trimester, if any trimester is not mentioned, then in pregnancy we are giving what? PTU. Are we done? Yes. So now these thioamides were PTU, carbimazole, and methimazole, all three can cause congenital malformation. Like, see, here the nasal passage is blocked. This is choanal atresia or aplasia cutis. Apl- Aplasia cutis, it is an absence of skin over here. So these are the side effects that are caused in the children when we give this drug to mother in pregnancy. Are we done? What drugs? Thioamides, PTU, carbimazole, and methimazole. Now, see, we know that iodine is in the follicle, it comes in the colloid, and this iodine makes T3 and T4. This iodine is stored here for 2 to 3 weeks. Sorry, 3 to 4 weeks. Now, what is the information? What is this information useful for? See, Now, if I give thyroperoxidase inhibitors, then what they will do? They will inhibit this formation, right? But we have already storage of T3 and T4 for the next 3 weeks, right? They will be going to blood, they will be causing symptoms. So, these thyroperoxidase inhibitors are slow acting drugs because they will inhibit the formation, the effect of which will be seen after 3 to 4 weeks when the storage things are getting over out here, right? So they are slow acting drugs and the action takes about 3 to 4 weeks. Done. So now let's see an example. A patient came us with hyperthyroidism. We gave him methimazole 10 milligram per week. After 1 week he came again. Symptoms were not relieved. We increased the dose. After 1 week he again came, no effect. We increased the dose. Next week he went into severe T3 and T4 decrease, severe hypothyroidism. Why? Because as we know that T3 and T4 were there inside the thyroid, right? We stopped this conversion when in the first dose of when we gave the first dose of methimazole, this conversion was stopped. But these T3 and T4 were causing symptoms, so he was not getting recovered. So we were increasing the dose. So we severely blocked this pathway by increasing the dose. So let's say zero T3 and T4 production was happening. So thyroid follicle did not have any T3 and T4. By the end of third week we gave him high dose of methimazole, so this conversion stopped. But during those 3 weeks these T3 and T4 which were already stored here, they were going in the blood and causing the symptoms. So after 3 weeks, when there was nothing, all these T3 and T4 were used, we stopped this conversation. At that time, patient went into severe hypothyroidism. So whenever we are giving this carbimazole, methimazole, we have to wait for 2 to 3 weeks. After that, its symptoms, after that, its effect will start. So just don't increase its dose. Done? Okay. The second one are secretion inhibitors. Now see, we studied that these are slow acting drug, but what if I stop this secretion over here? Then they will be fastest acting drugs because no T3 and T4 will be coming here, so no symptoms will be caused. So these NIS inhibitors, sodium secretion inhibitors, sorry, are the fastest acting antithyroid drugs because T3 and T4 is not even coming to the blood to cause those symptoms, right? So we have sodium iodide, potassium iodide, and Lugol's iodine. Now these T3, these secretion inhibitors are given before the surgery to reduce the size of the gland and make it less vascular so that it's convenient for the surgeons to do the surgery. If the gland has high size, then we can't do surgery, right? Okay. So the last drugs, sorry, second last drugs are thyroid destroying drugs. So we are giving a radioactive iodine here. First let's see the image, what's happening. See, we are giving See, we are giving iodine. We are giving oral radioactive iodine. So that iodine will be going in the blood, right? From blood, there is this sodium iodine symporter which will take iodine in this colloid and T3 T4 are formed. But this iodine is radioactive. So what will do is it will emit radiations and destroy this thyroid follicle. So it's good way, right? We took an oral drug which was radioactive, which helped us to destroy the thyroid gland. So it was radioactive iodine. Now the catch point is this sodium iodide symporter is present only in thyroid. Others or other organ don't have this symporter. So this iodine, radioactive iodine, won't be going to other organs like say let's say liver, kidney. These fellows don't have this symporter. So the iodine will be concentrated over here only. It will destroy this gland, this surface only. But can I use this iodine to destroy other organs? Let's say I used a radioactive drug which goes inside the liver. So do I, if I have a tumor over here in the liver, can I use this drug to destroy it? No, because this drug will emit radiations and destroy other organs also. Let's say the stomach is in nearby or pancreas, gallbladder, anything. Those organs will be destroyed. But over here what is happening is the iodine in T3 and T4 is releasing radiations but it is enclosed in this colloid. These follicles are entrapping the radiations. So radiations are not leaking out in other organs. So that's why we are using iodine therapy, radioactive iodine therapy to destroy these thyroid follicles. Done. We cannot use it for other organs, or we cannot just randomly use this therapy. Done. Okay, so this was the understanding of it. Now, the radioactive iodine used is iodine 131. It can be given orally, and it is in here the physical THAF. Physical THAF means after 8 days this radioactive iodine will be completely gone. Why? Because it has emitted all radiation and it's physically over. It's gayab ho gaya. Done. Now, the important thing here is it can cause irreversible hypothyroidism. Why? Because once the thyroid gland is destroyed, obviously it cannot make hormones, right? So if we destroy the entire thyroid gland, then it can cause hypothyroidism which cannot be reversed. If we are giving, let's say T4 is converted into, sorry, iodine is making T3 and T4. If we are giving the inhibitors like carbimazole, methimazole, that will reduce T3 T4 formation from iodine, but the gland is not destroyed. So they are reversible inhibitors, while these are irreversible. They are destroying the gland only. Done. So we don't give them in young patients or in pregnancy because the radiations will cause harm. Done. So they are contraindicated. Why? Because they are irreversible. They are destroying the glands. If we're done with this, now the last drugs are adjuvant drugs. What are these? In hyperthyroidism, we know we have sympathetic symptoms like tachycardia, palpitation. What is palpitation? Palpitation is the feeling of the heartbeat. Usually we are not aware that our heart is beating, right? But if it beats too strongly, we get aware of the heartbeat. That's palpitation. Tremor, hypertension, these are the sympathetic symptoms which are occurring. So for that we are giving beta blocker propranolol. So this drug is not reducing T3 or T4, it is just relieving those symptoms which are caused by hypothyroidism. So that is an adjuvant drug. Now, this propranolol has additional action that it inhibit peripheral T4 to T3 conversion. So it is decreasing T3, which is more active. So it is somewhat helping in hyperthyroidism, but its main job is to decrease all these symptoms. And it is the life-saving drug in thyroid storm. So thyroid storm we are studying. It is emergency hyperthyroidism. In that we give two drugs. One drug to control the symptoms, increase in heart rate and all. That drug is propranolol, and the drug of choice antithyroid drug to decrease T3 and T4 is propylthiouracil. Done.